So, welcome everyone to Department of Medicine Grand Rounds. I'm Eric Perschler in the ID division. And it's my great pleasure to welcome our 2024 Tim Gill visiting professor, Dr. Paul Sachs. Before I introduce Paul, I want to point out that we are deeply grateful to Tim Gill, who endowed this annual lecture series. He is the founder and co-chair of the Gill Foundation, which supports efforts to secure nationwide civil rights for LGBTQ Americans. And their present focus is countering discrimination based on sexual orientation and gender expression, and they've been a major factor in advancing acceptance and human rights for this community across the nation. Paul Sachs is the Bruce and Robert Beal Distinguished Chair and Professor of Medicine at Harvard Medical School. He is also the Clinical Director of the ID Division at Brigham and Women's. He received his MD from Harvard Medical School, then completed his IM residency at the Brigham and his ID fellowship at Mass General. Paul was also, in the past, the Associate Program Director for the Mass General Brigham ID Fellowship. He is also Editor-in-Chief of a very important leading ID journal, Clinical Infectious Diseases. He is Editor-in-Chief of Open Forum Infectious Diseases and Section Editor of HIV/AIDS and Up to Date. He's on the editorial board of the NEGM Journal Watch Infectious Diseases, where he writes the HIV and ID observations blog, and he serves as well on multiple other editorial advisory boards. Paul's research focuses on clinical trials of antiretrovirals, cost effectiveness of management strategies for HIV, and toxicity of antiretroviral therapy. Finally, I would point out, for those of you who are on X, formerly known as Twitter, he's been active and influential on ID Twitter with about 60,000 followers. His Twitter page says he prefers baseball to football, pizza to sushi, dogs to cats, and Beatles to Stones. So during this visit, we've kept him very busy, and we're very grateful to him for taking the time to do all this. Last night, he had dinner with several faculty and a fellow and community people living with HIV, and reviewed the HIV pandemic and advances in treatment. This morning, he spoke to the ID division on the future of HIV care and then attended our T32 trainee symposium. And he will now speak at this Grand Rounds on what my mistakes taught me. Paul, thank you.
Thank you. I don't need that, yeah. So want to thank Dr. Perschler and the ID division here for inviting me to come out and speak. As you just heard, I'm Paul Sachs. I'm an ID doctor at the Brigham in Boston. And I'm really excited to be talking about this topic today. And the reason I'm so excited is because I'm assuming that I'm not the only one who has made a mistake. And the reason I'm assuming that is because human beings, after all, are imperfect. And the inspiration for this talk came from this man who is an absolutely brilliant clinical teacher. He's the former chief of neurology at our hospital, who unfortunately died last year. And I don't know if anyone had the chance ever to hear him give a lecture. Has anyone ever heard Marty Samuels give a lecture? Okay. How was it? In fact, the guy was an incredible clinical teacher. And so, several years ago, he contacted several of us on the faculty and he said, why don't you do this talk that I give in neurology, but make it in your specialty? And I initially declined. And then eventually he twisted my arm and I did it. So here it is. It's going to take the following form. It'll be two memorable and two very different cases that I wish I had done something different on. I am predominantly a clinician, clinical teacher. I do some research as well. This is not their real names. I also am going to share with you something that happened during the pandemic and involving my job as an editor of a journal. I was the editor of Open Forum Infectious Diseases, and now I'm the editor of CID. And the term do-over, I very much would like a do-over on this one. So Let's get right into it. Okay, here's the first case. This is a 31-year-old man who was admitted to our hospital in late 1995 with a seizure. And here's his further history. He's lost 20 pounds. He has abdominal pain, diarrhea, and fever for at least a week. Extreme disabling fatigue, so bad he can't work anymore. He's terrified he has AIDS because several of his friends have died of AIDS, and he's never had an HIV test previously. And just to orient you about the timing, this was in the early 90s, mid-90s. This was the leading cause of death in young adults in the United States. And he was at risk. He worked in design. He was sexually active with men. He told him that his parents, who lived in Honduras, were unaware of the fact that he was gay or that he had been sick. And if you walked in the room, you'd immediately see someone who looked like they had either advanced HIV disease or cancer. He was wasted. He was febrile, had thrush, abdominal tenderness. He was awake and alert and interacting, but seemed very, very flat, very discouraged and depressed. He was offered an HIV test by the medical house staff. And at that time, they actually had to sign a written informed consent, but he refused to sign it. He said, I'm not signing that. If I have AIDS, I'm going to die. But the house staff, they sort of did an end around and they send a CD4 cell count. So that happens sometimes. It wasn't actually very common that people refused to be tested, but there was a group who said, why get tested when the treatment's so bad? And he was one of the more memorable ones. So not surprisingly, he had a seizure, so he gets an image, and the image shows that he has multiple enhancing lesions in the brain. I've outlined one in red. They are enhancing with contrast. And the radiology report says likely represents an infectious process such as toxoplasmosis, CNS lymphoma, may have a similar appearance, though the presence of multiple lesions makes this unlikely. So I am the consultant on this case. He's on our medical service. And I put together my formulation, which is, if anyone who's a specialist in ID could do this. And I said, well, he probably has advanced HIV-related immunosuppression and AIDS. He probably has CNS toxoplasmosis, the most common cause. He has diarrhea and wasting, and I'm not sure what that's from, but that's really common in untreated HIV. And also, he's just very depressed and socially isolated. I recommended empiric treatment as we gathered more information, and that included an antibody to toxoplasmosis, stool studies, and a social work consultation. So, to remind you, for those in general medicine, that the way we approach these mass lesions is we kind of hope it's going to be toxoplasmosis, because toxoplasmosis is treatable. In fact, it's so treatable when we have a case and we start the therapy. Often people get better within literally days, even though they have multiple enhancing mass lesions. And I put a picture of Arthur Ashe here because the professional tennis player actually was diagnosed with AIDS when he had CNS toxoplasmosis and lived another 5 years afterwards. And this was before we had effective antiretroviral therapy. Now, PCR tests are now used to confirm the diagnosis of the CSF, but they were not available, at least not for clinical use in the mid-90s. So that's the case so far, but obviously it didn't go well, or else this would not be a mistake. So over the next several days, he on the pyrimethamine and sulfadiazine, he started to get worse. So he had fevers, diarrhea, and became much more withdrawn. I also will say that his CD4 cell count came back at 210. His toxo antibody test was negative. All of his stool studies were negative. And his sort of affect became increasingly withdrawn. And he tells me that he's ready to die. This was very notable. And I know that the ID doctors are sitting there thinking, that's not consistent with CNS toxoplasmosis. That CD4 cell count is too high and this antibody's negative. And so I'm trying to figure out what's going on. Why is his CD4 cell count over 200? I actually went to some of the largest case series. They actually came from France, and I remember seeing that there was a range. There was an occasional case that happened with higher CD4 cell counts and the occasional toxoantibody negative. That was certainly not expected. And also, he wasn't getting better, which is not what I was expecting. So what else could be causing the brain lesions? I put this cartoon up here and it says, we will make the problem fit our solution. I think that's a real problem in clinical medicine. We have a tool or a treatment and we want it to apply it, and it's not always the right one. So part 2 of my assessment is that he, has fever and diarrhea, and I can't figure that one out. But as I just sort of put that in the kind of like, untreated HIV, fever and diarrhea are common. That's something we'll deal with later. I fell for this trap, the answers simple but wrong. That's the easiest pathway to go down, or complex but right. And then the depression was really, really very evident and hard to make us care for him. So am I missing something? Well, I'm going to share with you a construct of clinical care that I found very useful. And does anyone recognize the picture of the person there? Who is that? That's Conan O'Brien. Now, why on earth would I have Conan O'Brien's picture up here? If those of you who are really into ID trivia will know in a minute. But anyway, here's the scenario. You have a 2x2 table where, along the horizontal axis is whether the patient's getting better, along the vertical axis is whether you know the diagnosis. And obviously, everyone wants to be in state 1. And no one wants to be in state 4, and that's usually where we get our ID consults, the people who are not doing well and people don't know what's going on. But the most common in the outpatient setting are they're getting better and you're not exactly sure what it is. It happens all the time. And then in the inpatient medicine side, you have someone with so many comorbidities and chronic conditions, you know what's going on, but you can't really do much about it. It turns out that Conan O'Brien is the first person I heard with this construct. Not Conan O'Brien, Conan O'Brien's father. Conan O'Brien's father is Tom O'Brien. He's an ID doctor at Harvard for years and years and years, who just happened to have this brilliant comedian as a son. And he was also quite funny himself, not surprisingly. And he would sometimes say to me, what state is the patient in? The cellulitis not getting better. It's cellulitis, but what's going on? That's 3. You want to move them over towards 1. All right. So back to the case. This is I think the best data on the occurrence of opportunistic infections in people with untreated HIV. It was a study done out of Hopkins right before we had effective therapy. And you'll notice the individual opportunistic infections and toxoplasmosis is down there, okay? And the CD4 cell count, the median is under 50. Under 50. In fact, if you look at all these opportunistic and complications, most of them don't happen until the CD4 is really below 100. So this is starting to seem like it's probably not toxoplasmosis. So I'm going to pause here and put a question up for you. I'm going to invite my ID colleagues who've been so generous with their time over the last day to weigh in. And who should I call on? Anyone want to weigh in? I won't do the cold call. TB says somebody. What do you think? TB. Any takers for anything else? Way in the back. You think cysticercosis? Okay. Any other volunteers? By the way, I've seen one case of CNS Chagas disease. One, and it is the appearance of this quite similar. But anyway, so you hear about cognitive biases all the time when people talk about clinical reasoning, and this is one of many definitions. It's just shortcuts that you're going to do just to get to the answer. You're not aware of them, of how they affect you. And it's so common in day-to-day life. This is how we get through life. You can't meticulously go through every possible diagnosis, so you use your cognitive biases to come up with the right diagnosis. And here are 4 that are active in this case. The anchoring, where you rely on the first piece of information that you see Availability, the one that comes to mind the most quickly, that's certainly here. You fail to notice other things, like you exclude data that doesn't fit your hypothesis, or then the opposite, the confirmation bias, which of course is rampant in social media, where people only get new information that supports what they agree with, but they actually kind of sometimes tune out the other factors. I was totally thrilled with the Stelzer poll, for example. Wait, am I allowed to discuss politics? Sorry. that Stelzer poll is like, great. All right, I probably put too much attention on that. But the problem with cognitive biases is that we're not aware of them. And another problem with them is that they're just too many. They're too many. And I found this figure on the internet. Whoops, sorry about that. Found this figure on the internet, and it was like, wow. And so, rather than memorizing the cognitive biases, instead, just realize we have limitations in memory in particular. When you have a case that's not going well, seek the perspective of others, critique frequently, explicitly take the time to think through the problems, and don't try to remember them all. So it's in essence, when we have a tough case, we want to do the opposite of what this man is telling the cat. We want to try to think outside the box. So do not be a cat here. All right. This allows me to pause for a moment and share with you, every so often something happened during the pandemic that was just so wonderful that you realized how grim life was otherwise. And this particular event happened. If you have not seen this video, please go to your video source of choice, YouTube, and search "I am not a cat." Because this man appeared in court using his daughter's computer. And his daughter's computer had a cat filter on it. And that led to the man saying, in all seriousness, as these two other lawyers tried to address him, "You have a filter that shows you're a cat." And he said, "I am not a cat." All right. So I guess, in hindsight, what should have happened next? And I don't know why I'm getting the feedback. I guess I could turn the microphone off, right? Okay. I should have, broadened the differential diagnosis. Lavalier, maybe that's the one that's got to go off. Okay. Oops, still on. Well, if there's an easy way to turn it off, I haven't figured it out. Okay, so you broaden the differential diagnosis. Hello, help me. Thank you, MFA. Okay, all right, there we go. You broaden the differential diagnosis, you get the neurosurgeons involved, you do additional studies to figure out what's going on with his diarrhea, you get psychosocial support in place. All right, well, you get the technical challenge solved and you don't have feedback anymore. Anyway, those things didn't happen. What in fact did happen was as follows. The neurosurgeons came by after a consultation to say, "We'd like to do a brain biopsy." Can you imagine the interaction between the neurosurgeon and Miguel? It's probably 5 a.m, right? They go in the room, they'd say, "We'd like to do a brain biopsy." And he goes, "I don't want it done." And they'll walk out. So he had a blood sent for all kinds of other studies. He told the social worker he'd rather die. This is like he's totally stigmatized by having HIV. And despite our protestations, he left the hospital under the care of a friend, and he died 2 weeks later. And as you correctly surmised, he did have tuberculosis. His blood and stool cultures both are positive for TB. Undoubtedly, the CNS lesions were disseminated tuberculosis. And not only that, this happened in 1995, and a year later, we had this miracle of antiretroviral therapy. And had he only survived until then, he would have had access to it. And this was such an advance. It was so exciting. And I get to, make fun of the younger people in the room and remind them that this is how we used to see our news. It used to be in magazines. magazines like this, where we had in 1996, Magic Johnson and David Ho appearing on magazines to sort of herald in this new era of HIV treatment. Very, very exciting. So my mistakes here, I was fixated on the most common causes of mass lesions. Data came back and didn't fit. Higher CD4 cell count, negative serologies. It was very hard to change gears. I mean, I tried, but I didn't really push it. And then also the fever and the abdominal pain and the diarrhea, those are very classic in disseminated tuberculosis and AIDS and very common in syndromes like this. And I should have factored in the imminent arrival of effective HIV therapy. We already knew in 1995 these treatments were looking better. So I would have strongly advocated a more aggressive approach. I have to admit, his depression ended up playing it deeply into my own somewhat passive role in being his advocate during his hospitalization. So let me pause there and see if that case, if there are any questions about that case. Anybody? And if you want to think of it and ask later, feel free to save it for later. Steve. He spoke English, but not well, and that, of course, adds to the difficulty of caring for people in the hospital. You know, I do think that the tablet interpreters are much better than having, you know, nobody, obviously, and it's better than the phone, but it's still not as good as having someone who could really speak the language fluently with him. Well, this one has got a less serious outcome. It's Courtney. And again, of course, this is not Courtney's picture, but it's someone who looks like this. So this is how this case started. We have our weekly case conference every Monday morning at 8, and I run that conference. And Sunday night, I have little premonitory anxiety to get ready for it. And Josh, you can remember this? Yes, you do? Okay. And I basically, for the time between 7:15 and 8 o'clock, I don't want to be bothered, but I got paged by the hospital president. It was actually his assistant. She says he wants to speak with you. And it's, hi, Paul, thanks for calling. I tried to reach Dr. M, but he's away. There's someone I'd like you to see. It's the daughter of a big hospital donor. And I actually had heard of this person, of course, but I did not put his name up here. And this daughter, she's driving up from their house on Nantucket from their horse farm in New York. And Mr. Mega Donor thinks his daughter might have Lyme, and thanks in advance. Okay, a few things about this page or this conversation. First, there's all of these signals of how important this is. Second, it's Lyme. I'll talk a little bit more about Lyme momentarily. And third, he said, thanks in advance. And I hate when people say thanks in advance. I don't know why it bothers me so much. I'm married to a primary care pediatrician who says, I used to say that all the time, but then you told me you didn't like it. And I wish you would just get a life and get over it. So, but I like it when people say thank you. I like it when people say thanks, but thanks in advance. I don't know. There's something about that term that makes ID doctors feel very underappreciated. Anyway, so thanks in advance, she says. So this is how the case could have gone. Okay, it's a 23-year-old woman with a rash. She noted it yesterday behind her left knee, no fevers, chills, or palpitations, no past medical history. She's taking only oral contraceptives, no allergies. She lives in New York City. She spends the weekends on her family's horse farm in upstate New York. She has ticks everywhere. And so I do a very targeted exam, and there's a healthy appearing young woman, rash as shown. And she was given doxycycline and did well. Okay, just bread and butter medicine in New England. And I got to tell you, Dan Koritzkis, when he came here, came to Boston from Colorado, like over 20 years ago now. He said one of the biggest differences were these tick-related infections. Has anyone here lived or gone through a summer in Boston as a clinician? Josh has. Lyme disease, anaplasmosis, babesiosis, just like you see tons of it, you know. So anyway, just to make it clear to you, we see this all the time. We see this all the time. All right. So this is what really happened. So I'm waiting for Courtney, who is at least half an hour late for our scheduled appointment. And I'm thinking, I wonder if she's going to come. I've got sort of mixed feelings about this. On the one hand, I told the hospital president I would see her. On the other hand, I'm not liking the way this is going. And then Courtney arrives. She's out of breath. Hi, Dr. Sachs. She was very nice. She goes, thanks for seeing me. Sorry for being late. Traffic was terrible. I have a driver waiting outside, and we need to be on the road quickly to make the ferry. Ticks are everywhere on our horse farm. Can you take a quick look at this rash? She shows me the rash, and I say, it looks like Lyme. We treat this with doxycycline. Do you have any allergies, any other symptoms? And she goes, nope. Thanks so much. Please call the prescription into the pharmacy on Pleasant Street in Nantucket. Thanks again, gotta go. Bye. The total time of this visit could not have lasted more than 5 minutes. Absolutely no way. But, you know, made the diagnosis, gave her treatment. So that was Monday afternoon. Next day, on my pager, please call ASAP, Courtney. And so I call her back. She goes, hi, Dr. Sachs. I took the first pill this morning and I feel worse. I now have a fever of 101.4. I'm shaking so bad, my teeth are chattering. Are you sure this is the right medicine? So I ask you, what's going on here? What's going on here? What is this? Yeah. So these are the possibilities. One, A is unlikely. A is unlikely because anaplasmosis responds to doxycycline. B is possible, but you don't hardly ever see severe babesiosis in a healthy young woman. It just basically, it's mostly older people and people who are splenectomized or immunocompromised. Drug allergy for doxy, probably not the case. What about powassan? Powassan, we've started to see all of these cases of encephalitis, a variety of different severities from this virus. Could be, but doesn't really fit. But that host immune response, that's what this is. And you know, this is basically like when you treat syphilis, you can see this and you warn people about it. When you treat Lyme disease, you see this and you warn people about it. And you know, the people who are most likely to get it have multiple lesions of erythema migrans over their body because they have disseminated disease and a high burden of organisms. You might even examine her. I mean, I basically just looked behind her knee. I mean, she could have had erythema migrans lesions all over. And it's a host immune response. And in case you were wondering who those people are, that's not Conan O'Brien and his father, Tom O'Brien. That's Yarrick and Herxheimer, but I don't remember which one's which. So there's the case so far. It's not going so well. And especially not going so well that night, nearly midnight. And I get a call from Nantucket Cottage Hospital, which is the only hospital on Nantucket. And it's a doctor who's Dr. Smith, and please call ASAP. And Dr. Smith, she says to me, Dr. Sachs, I have Courtney here with fever and chest pain. Her temp is 100.5. She's got multiple erythema migrans lesions. Oops, I guess probably should have examined her. Her pain is 10 out of 10. Severity, worse with swallowing. Okay, EKG is fine. So what's this? What's this? Well, you know, again, ID doctors, our very favorite antibiotic is doxycycline. It's incredibly broad spectrum. It is the drug of choice in any summertime fever in Boston. Absolutely. There are almost no exceptions. If you see an adult who's got a fever of 102 and shaking chills, it's probably better to put them on doxycycline than to just see how it goes. It's that common in the summertime, because how often do people get fevers in the summertime? You know, adults I'm talking about, not talking about pediatric fevers. So anyway, very few side effects. Pill esophagitis, though, is one of them photosensitivity, nausea, and it protects against C. diff, and so doxycycline. And I did this antibiotic draft with my friend and colleague, Rebecca Plank, several years ago, and we each get to choose our favorite antibiotic, and she drafted first, and she chose doxycycline, and every ID doctor, I think, would have done the same. So it took that one off the board. But pill esophagitis, if you've ever seen it, is really a severe pain syndrome. And the most common cause of pill esophagitis in the antibiotic class is tetracyclines by far. And so when you are prescribing doxycycline, part of the counseling is to actually tell them that you can't lie down for at least an hour after they take the medication. And she, of course, took the medication right before bed. And that is not what you're supposed to do. And you'll see that in this slide, it says swallowing pills at bedtime without water is commonly reported. Indeed. So retrosternal pain, heartburn, odonophagia. Sometimes people are actually admitted to the hospital because the pill esophagitis is so bad. It gets better over a few days. So her fevers got better. She continued to have pain and swallowing, ultimately changed to amoxicillin, completed the 14 days of treatment. She did fine, I think, although I never heard any follow-up. Suffice to say, her father never donated a giant grant to our hospital in our name, in his name, but that's the way it goes. So mistakes in this case. So I think the nature of the referral completely messed up my usual clinical care. It was an urgent page from the hospital president. She said, thanks in advance. I was the second choice doctor. Dr. M was the first choice doctor. It's a VIP patient, daughter of a big hospital donor. In a big rush, the driver's waiting, can't miss the ferry, and she rides horses. Find people who ride horses very intimidating. So because of this, I didn't go through my usual strategy of educating her about what to expect. I didn't examine her fully. I didn't say, you might get a fever the first day. You should take this with plenty of water and stay upright for at least an hour. So I have this picture here. This is a portrait of someone who was a longtime clinician at our hospital. He's retired now, Marshall Wolf. And he had this fascinating practice because everybody knew he was one of the best doctors in Boston. So everyone wanted to be his doctor. And he basically had accumulated a patient panel that included most diverse people you could imagine. He was taking care of people in our community who, longtime Bostonians who worked in service industry, people who worked in the hospital, people of all races and ethnic backgrounds. And he also had, Fortune 500 executives and Nobel Prize winners and professional athletes and you name it. And I said to him, Marshall, how do you treat these VIP patients? I find it so challenging. And he says, he was very gruff. He would say, you just treat them like everyone else. That was his advice. That's all he would say. And every time I'm in this process of trying to feel like, how am I supposed to navigate this VIP patient? I remember the words of Marshall Wolf: treat people the way you treat every patient, these VIP patients. So there is a literature on this, of course, and the risk is both under care, like the way I did here, and the other risk is over care, where you do too much. So you can actually be in both situations simultaneously. I remember once when one of our division chiefs got admitted to the hospital. There was a lot of with a GI bleed. There was a debate: should this person get an NG tube? Well, there wouldn't have been a debate if the person weren't known to everybody. And so ultimately, he asked, shouldn't I get an NG tube? Delays in treatment, and I got to say this is very common. And when people are surveyed, when we doctors are surveyed about the care we might give to VIP patients, we are understandably uncomfortable about it. Now, I'm going to share one of the truly tragic mistakes of Boston medicine, which involved Reggie Lewis. Reggie Lewis was a very successful professional basketball player in the 1980s and early 90s. And he collapsed on the court and sought the attention of the dream team of Boston cardiologists. The dream team, he got admitted to a private hospital. The dream team came from the Mass General, the Brigham, Beth Israel, the smartest cardiologists. They came in to this private hospital. They didn't have privileges there. They got emergency privileges, and they rendered a decision. They said, Reggie Lewis, you have cardiomyopathy. You're going to need an ICD, and you're never going to be able to play basketball again. And Reggie Lewis, understandably, did not like that. And his wife did not like that. And they took him out of that hospital against the medical advice of the dream team. And they brought him to another hospital where a different cardiologist examined him, did further tests, and said, nope, Reggie Lewis, you have a normal athlete's heart. Well, that was, of course, what they wanted to hear. That's what they wanted to hear. So what was the truth there? They then, Reggie Lewis and his wife was very, very much involved in his care, took him to a third place for a complete evaluation, who said there were features of both a normal athlete's heart and the cardiomyopathy, and they couldn't make an assessment. So with those three opinions, Reggie Lewis went back to playing basketball and then died while playing basketball. And so this case has been sort of haunted us in our city for years. I don't know if are people aware of this at all, that this happened? And it just shows the warnings about VIP medicine, something we all have to remember. So that's the end of that case. Any questions about that one? Has anyone ever experienced this? Or does maybe, yes, no? Does this come up sometimes? Oh, no VIPs in Colorado? Eric.
Similar experiences treating colleagues.
Yes. So definitely treating colleagues is another challenging aspect of VIP medicine. Even though they may not be VIPs, they're just your colleagues. Colleagues and friends can be another very difficult situation. So, all right, on to the third case, which is pandemic related. And I wanted to just share this experience, this cartoon. My sister is an architect, and she loves to draw. And I said to her, it was probably 2021. It was about a year into things. And I said to her, my life is kind of sucks. Here's why it sucks, because all the things that I used to have in a nice balance in my life have been overtaken by this beast that is COVID. And so I said, can you do a graphic representation of my life before and after COVID? And she came up with this. So you can see the pie, and it's got teaching, administration, research, patient care, fun and family, kind of nice balance. And then this came along, and basically life was horrible. There were things that maybe were good about it, that I am not a cat video, but that's not enough to compensate for how terrible life was for ID doctors. So in January of 2021, I got an email from a former colleague who had gone to work in Kansas. And he said, long time no see, greetings from Kansas, you're a cardiologist. I saw you are the signer of the letter on scientific analysis of COVID treatment to the NIH. Would like your thoughts on ivermectin. The local doctor in my community has been using it for months, combined with doxycycline and zinc, including an extensive nursing home outbreak involving dozens of patients and staff, 0 deaths or hospitalizations in a group that should have had several of each by now. Also, did you see Andrew Hill, University of Liverpool, meta-analysis that they presented to the WHO and NIH? Check it out on YouTube, 83% mortality reduction. Well, first is Bill. Bill, I remember Bill. Bill was a no-nonsense dark doctor. He went into cardiology, and then he went into practice in small town Kansas. And he was a sensible person. This is not a picture of Bill, by the way. This is a marker for Kansas. And so I went to YouTube and I searched Andrew Hill ivermectin, and I found this presentation. Andrew Hill is a PhD who does HIV clinical research. And I know Andrew Hill. And there it is. There's all these there's observational studies and the randomized clinical trials, and there in the big circle is the reduction. And he was speaking in English, but they translated it into Spanish. And so that's the beginning of this error that I'm about to make. But I'm going to ask right now, so which of these repurposed treatments for COVID-19, which one did you think had the most promise that later turned out to be a bust? Okay, I've got hydroxychloroquine, lopinavir, ritonavir, fluvoxamine, ivermectin, something else. All right, let me ask Christine to answer this one. Hydroxychloroquine. Okay, so in our hospital system, which includes both the Brigham and MGH, the MGH actually wrote hydroxychloroquine into their treatment guidelines right from the get-go. We did not, so they agreed with you. All right, anyone else want to weigh in? I can tell you that I thought fluvoxamine was going to work because there was a 60 minutes on fluvoxamine. Did anyone see that? A special fluvoxamine 60 minutes. All right, so nobody chose ivermectin. All right, well, anyway, I do write this thing. I write a blog. I hate the term blog, but that's what it is. And I've been given the license to write about whatever I want by the nice people at New England Journal of Medicine. And they really let me write whatever I want. There is an editor. The editor goes through it to make sure I'm not saying anything that's kind of not, appropriate for family readers, and they sometimes say you can't use that image because it's copyrighted. We don't want to get sued. So I took a look at this ivermectin thing. I wasn't sure whether it was going to be a breakthrough or a hydroxychloroquine redux. And I had to put a picture in my blog of a sulfur-crested cockatoo. And I chose that because I couldn't find a better image. And it was in the public domain. That was the reason I chose it. So I wrote my take-home view: the clinical trials data for ivermectin look stronger than they ever did for hydroxychloroquine, but we're not quite yet at the practice-changing level. Results from at least 5 randomized clinical trials are expected soon that might further inform the decision. The NIH treatment guidelines still recommend against it, a recommendation I support pending further data. We shouldn't have to wait long. So that doesn't sound so bad, does it? That's like pretty balanced. I haven't made the mistake yet. But then I got an email from Andrew Hill, and he's asking me whether I can advocate for him to get his meta-analysis published in the New England Journal of Medicine. Well, I don't have the power to do that, just to put it mildly. So I said, what did I say? I said, New England Journal of Medicine rarely publishes meta-analyses, and since the randomized clinical trials have not been peer-reviewed or published, correct me if I'm wrong, I think it would be a long shot, but I'm not on their editorial board. I'm not. I just write this blog for them. And then I said, if this is the mistake, if your goal is to get it published quickly, we can expedite it through open forum infectious diseases. It certainly isn't the New England Journal of Medicine, but it has a solid ID founding. So there it is. He submitted it. And I read the paper. We got it reviewed. There was a lot of controversy on my editorial staff about whether we should publish it or not. And at the same time, I asked Mark Seidner, who's a very good clinical trialist, to write this editorial. And he gave a very balanced view of this paper and this meta-analysis. And he raised a lot of red flags. He said, no biologic plausibility, heterogeneity in study designs. The studies hadn't been reviewed or published in peer-reviewed journals. Some aren't placebo-controlled. They're not listed on clinicaltrials.gov. Just very, very concerned that this wasn't accurate. Meanwhile, in the background, there was this lunacy going on about ivermectin. I'm talking about lunacy. I don't know how many people were familiar with this group, the FLCCC. They basically said, we are frontline COVID critical care clinicians, and we know what's right for patients, and we have all of the data we need to give this life-saving treatment. So that led to lawsuits where patients admitted with COVID insisted that they get ivermectin, or their family members insisted that they give ivermectin. And it prompted, ultimately, when there was use of veterinary ivermectin, the FDA to step out of their usual role and actually be funny for the first time ever. This is the only time the FDA has ever been funny. And they said, "You are not a horse, you are not a cow. Seriously, you all, stop it. You stop it." Now, I'm very sad to say that the FDA was asked to take this down, but I have it captured for posterity. So anyway, there is the paper. Notice the date, 6th of July, 2021. And then huge studies supporting ivermectin as COVID treatment withdrawn over ethical concerns. Notice the date, July 15th of 2021. So as soon as we published this, as soon as we were starting to get attention for it, we realized that the data on which this meta-analysis were based were flawed, seriously flawed. And so we had to issue a retraction. If you are a journal editor, you do not want to issue retractions. These are always flagged. They're like a real black mark on your reputation. And I have to give credit to Andrew Hill. He immediately contacted me when the data, the problems with the data came to light. But that did not stop me from getting quite a lot of attacks. I have to say, you know, being an ID doctor during COVID, you tried to have a low profile. It was almost impossible. It was like constantly getting involved in controversies like this. So there were people who blamed me for this flawed study. There were people who blamed me for publishing it. I guess I should take the blame for that. There are people who blamed Andrew Hill, and on and on and on. And then there were the people who still wanted to give ivermectin, who said, despite the fact that the data are flawed, it's still the best treatment. So anyway, to Andrew's credit, he redid the meta-analysis. He left out all of the flawed data, and he found that it didn't work. And now we know from several other randomized clinical trials, it doesn't work. So happy ending, sort of. All right, so my mistakes there. I got overly influenced by the opinions of people I knew and I respected. So I have a former colleague who's, you know, a no-nonsense doctor in the trenches, and his anecdotal impressions in Kansas, as well as Andrew Hill, who was a well-regarded HIV clinical researcher. I was eager to make a big splash in our journal, OFID, which is the preferred abbreviation for open form infectious diseases, not OFID. I thought this could be a good way of getting attention to our new journal. And my generally optimistic nature, which I shared already with Eric, it's got the better of me. You know, I thought maybe it did work, and wouldn't it be great if a repurposed drug worked? So anyway, that's the third case. So to conclude, consistently giving good quality patient care is hard. It's very difficult. Cognitive biases are everywhere. There's so many, you can't remember them all, but remember them when you are having trouble with a case. VIP patients pose special challenges. And when you are involved in that, step back and say, how would I do this to anyone? Scientific data that look too good to be true usually are, and that's the correct grammar. Learning from past mistakes is critical. I have to go back to Marty Samuels now and say that he thought that looking at your mistakes was a great way of improving, because it was kind of like an evolutionary process. You weeded out the mistakes so that you didn't make them again. So I want to thank him, and, you know, may he rest in peace, Marshall Wolf, Mark Seidner, and Carolyn, my wife, who is there with our dog, Louie. And thank you again for inviting me today. Any questions or comments?
The NIH COVID-19 treatment guidelines, often the number 1 or number 2 page view was ivermectin. And this was well after.
Say it in the microphone.
Yeah, for the NIH COVID-19 treatment guidelines, the number 1 or number 2 page view was kind of consistently ivermectin, even well after the antiviral drugs that work to some degree were reported.
It was really fascinating. It became this sort of mass psychosis that it happened in multiple countries. You know, it was something that was going on both here in North America as well as in Latin America, Europe, just a sort of staggering bit of insanity. I don't really understand it. So who would know? I mean, ivermectin has its uses, but this isn't one of them. Good. Great.
Thank you so much for your talk. For those in the audience that are trainees, how do you think about the mistakes that you make as a trainee, how that you handle those differently, how it influences what you do?
So I guess that, even though I wasn't a trainee when the Miguel case occurred, it was so long ago that I was really a young, inexperienced ID doctor. And I think that the message is when, and this is another thing that Marshall Wolf taught me, when you're in trouble, when you're feeling you're in stage 4 or the patient's not getting better and you don't know what's going on, just go and get help. I mean, it's one of the reasons why I think American Board of Internal Medicine recertification process is flawed, because you're not allowed during that test, the proctored test, to get help from your colleagues. It's so unrealistic. And even the one you do at home, you've got 3 minutes, 4 minutes to answer the questions. It's hard to get, input from your colleagues during that time. So I think that that's a key part of delivering good patient care. And I actually sometimes think I worry about the doctors who are, isolated from others, so they cannot reach out to others and get help. It's really, really important to have that humility. Great. Oh,
So,
thank you.
so this is really nice, and we all make mistakes.
Yeah.
And it's really nice to see you go through the whole process. Some people,
By the way, I've made more than that.
some people, when they make mistakes, aren't sufficiently self-aware or self-reflective. But the opposite problem in medicine, and especially with compulsive ID docs, is we can really beat ourselves up.
Yes.
So how do you
Yeah.
think about
Well,
processing?
I think one of the benefits, again, of reaching out to your colleagues, or what I encourage them to do, is I say, look, you've got a tough case, discuss it at case conference. Even though there's a chance that at case conference it might get revealed that you maybe don't know the answer to something, but that's okay. I mean, the other day, and I have a really good example, a 23-year-old woman was admitted to our hospital with a encephalitis-like picture. And it turns out that the process had started a couple of weeks before. She had acute respiratory illness. When we heard the case at case conference, this sounded like a case of post-mycoplasma-induced neurologic syndromes, one of these strange mycoplasma non-pneumonia events. And that, in conjunction with the fact that the CDC issued an alert about a rise of cases of mycoplasma in the pediatric and young adult population, and frankly, the fact that I'm married to a pediatrician, I said, this is almost certainly going to be mycoplasma. And there were just for the young ID doctor on that case, just presenting a case conference was very useful, because the family's terrified. And they can go back and say, we discussed it at our case conference today. This is what we think it might be. I'm not just going to say I'm so brilliant. It was mycoplasma, but at least gives you an idea. It moves you from state 4, where you know the diagnosis, to the one where you do, and that's a much better place to be. And there's some evidence that corticosteroids might be useful, et cetera. So anyway, just an example. That doctor, to his credit, he brought that tough case to the conference, one he was struggling with. Josh.
Thanks, Dr. Sachs. So it's one thing, I think, to admit to our colleagues that we're wrong. We don't know the answer. I think that the world is outside of these walls is a little changed over the last, I don't know, 8 years. And I'm curious how, if you have ways in which you've started to interface with people outside of medicine, whether through social media, blogs, et cetera, on being able to admit that science and medicine are a learning process.
Yeah.
And because I think that we've sort of strayed from that as a larger society. And I was curious, you're such a good orator at this, how you've navigated.
So in social media, if you make a mistake, you'll be they'll notify you instantly. You know, the mobs will descend. And the right thing to do, in my opinion, is you immediately apologize or you delete the original error and then you say, I've deleted the original one. This is correct. Thank you for the feedback. You know, do not get into fights in social media. It is a losing battle. Swarms of people will come after you. I got tremendously attacked for an overstatement I made about COVID vaccines and prevention of transmission. I mean, they probably help to prevent transmission in the first 3 to 6 months, but then they probably don't do much in that regard. But I didn't know that at the time, and I was so optimistic about it that I took a lot of heat, and it was unpleasant. And I don't get into fights. So I thought you were going to ask is how do you acknowledge mistakes to patients and family members? And there it's very tricky. I mean, you just got to be as out there as possible. Say, look, we with all the information we had available to us, we thought this was the diagnosis, and it turns out it was something else. I had that happen recently with a case of someone who was admitted with lymphoma. We didn't know it was lymphoma. We actually thought it was infection, and eventually the diagnosis was made. And the family asked me directly, he said, if you hadn't done all those ID tests, would we have gotten the biopsy sooner to realize that it was lymphoma? And I said, yes, but I saw it through my own lens that I thought it might be an infection. So it's just the way. Clinical medicine's hard. It is. It's very hard.
One more.
Thanks. Thanks for that great talk. I actually want to have a question that I'd love your thoughts on based on the last mistake, which is how to consider preprints, because they haven't had that step of peer review to consider the biases coming into it.
So reprints, they vary in quality hugely, as you know. Are you an editor at a journal? Are you sort of? Okay, but anyway, here's where reputation probably plays too much of a role. I mean, I have to say, when a highly reputable investigator puts out a preprint, it gets a lot more weight than someone who has no reputation at all, hasn't published on the topic. So that's probably the only thing I can say. It's very hard sometimes to look. I can't keep up with the reprint literature. They're a reality, and you're right. They're not peer reviewed. Often there's no comments there either. So it's not as if putting it on the preprint server, you're going to get a lot of feedback. That was, I think, the hope. So good question. Great.
Thank you.
Thank you very much.